know some of you all.
Okay, shall we start?
Yeah.
Good evening, all doctors. Thank you so much for joining us for this first ever webinar that we are conducting from the Alumni Association. We are calling it our Rural Outreach Webinar as we are tailoring it to all of you who are working in rural areas and are forced to practice more than just your specialties, where you'll have to deal with an entire gamut of conditions for which it might be a little bit of challenge for you, which is why we are organizing these classes to make certain complicated topics a little more manageable. It is a delight to have you all here. And let me say on behalf of the alumni, we are very, very happy and proud of all the work that you all are doing in the rural areas. More so at a time like this, when we are having COVID and you all are being so dedicated and working. Thank you very much for your service. I would like to introduce our president, Dr. Amaya Mascarenas. She will give you an introductory address and will introduce our speaker for today. Ma'am.
Thanks, Oliver. That was Dr. Oliver Rodrigues, okay, who looks after a career guidance section of and he's part of the Alumni Executive Committee. Thank you, Oliver. And I'm very, very thrilled that we can start this webinar. This is going to be the beginning of a series of webinars. It's not the only one. And we do hope by the end of this evening that you can also suggest to us topics that would be interesting to you, and so that we can plan them. And we are hoping that we can have at least 2 every month, if not more. So we can take advantage of this pandemic to have these online sessions. And we've chosen today and this time, after getting feedback from y'all, that this was a suitable time for everyone, because then they're a little free to listen. We've started with a topic that's a very, very common symptom. And, you know, even as a student, as an intern, you would have heard, you know, everyone complaining of joint pains, and joint problems. So what better way to start with something that you all find very commonly in your clinics and in your rural areas. A big, big note of encouragement from us. We're really proud of the work you're doing in your mission hospitals and in your rural areas. And you're really, like Oliver said, facing so many challenges, and on top of that, COVID situations. So I do hope you're all safe and healthy. And we're very, very proud of all of you Johnites, much more than, you know, any of the other alumni. I think you all are the most favored ones and most special ones, because you do the maximum amount of work in the very needy areas. So I'm going to move on and introduce our first speaker of the first webinar. And we're very happy to have an alumni Johnite with us, Benzeeta Pinto. She was a 2001 undergraduate alumni who graduated in 2006 and graduated with first prize in general medicine. She also did her PG in internal medicine and then her DM in clinical immunology and rheumatology from PGI Chandigarh. She's currently working in St. John's in the Department of Clinical Immunology and Rheumatology as assistant professor. She has special areas of interest with SLE and vasculitis. She's a member of several associations, including the Indian Rheumatology Association, and has multiple papers and publications to her name. She's a reviewer of several journals and author, and she also has another side to her. She's a poet, writes short stories, and I'm very happy that she shares my passion in music, and she is trained to sing in Carnatic classical music. So maybe at the end she'll even do one rag for us. Maybe. But with no further ado, I want to say welcome and to Dr. Benzeeta, and over to you. And we look forward to a very interesting session on joint issues. And since it's a webinar, you may not be able to actually ask questions verbally, but there is a chat box and we welcome you to put in any questions you have. At the end of the session, after she finishes her talk, we will take up these questions and she will try and answer as many as she can. Over to you, Benzeeta. and welcome everyone else. I also just want to quickly welcome Robert Anthony, our Vice President, and Mario, who are hiding. Mars is our Outreach Secretary, and they're pillars of the Alumni Association Executive Committee. And we have quietly working in the background Dr. Tony Raj, who's the treasurer of the Alumni Association, Dean of St. John's Research Institute, who has helped us to get the whole technical support team to put up this web link site. And so this is also going live streamed on YouTube. So for those who miss it today, there will be a recording that we put up for you and for so that you can share it with others later on. Over to you, Benzeeta.
Thank you, Dr. Maya. This is a wonderful opportunity indeed. And I have done some part of my bond. So I really think that it is indeed a challenge to do the rural bond, especially in the places that we do have bond centers. So kudos to all of you. And I have tried to kind of make my presentation directed at generalists. So I'm sharing my screen. So I'm going to talk about how one does approach to a patient with joint pains. Okay, so give me a minute. I'm unable to move the slides. I'll share it again. I'm unable to move the slides. There is.
Benzeeta,
Yes.
you need to share your entire screen, not just the screen, the entire desktop.
Okay. One second.
When you say share, you get multiple options.
Yeah.
And now, yeah.
Yeah. Okay. So why is this topic important? Because in general practice, if you look at general OPDs, the musculoskeletal disorders are extremely common, and a huge chunk of general medical practice will be musculoskeletal disorders. The prevalence varies from 20 to 30% in most of the largest series, and it's the single largest contributor to disability. It is, of course, because a lot of these disorders are more common in women, and also because we have a largely aging population everywhere, especially in the Western world. So that is also one of the reasons for increase in the prevalence of musculoskeletal disorders. It is linked with a lot of psychosocial comorbidity, including depression, and also there is an association with musculoskeletal disorders and other chronic health conditions, because diabetes and hypertension and other cardiovascular disease are associated with metabolic syndrome, are associated with musculoskeletal disorders, and it has, of course, vast social and economic implications. So as a rheumatologist, for us, it's a core symptom, joint pain. Okay, so when a patient comes to us, the first thing we obviously ask is for the presence of joint pain and the associated functional disability. So when you come to the first question to analyzing the symptom of joint pain, we want to figure out whether this pain is a regional pain or is it a widespread pain. Because obviously, if the pain is regional, the differential diagnoses are different, and widespread pain, we have a completely different set of differential diagnoses. So in history, the gender, of course, there are certain disorders which are much more common in males, like, for example, gout, which is the most common inflammatory arthritis that we see in practice, spondyloarthritis, ankylosing spondylitis. This entire group is much more common in males. OA of the hip, reactive arthritis, all these are more common in males. In females, immunological disorders like rheumatoid arthritis, connective tissue disease are much more common. OA of the hand is far more common in women, and fibromyalgia and chronic pains are more, almost 2/3 are going to be women. The age has an impact on the diagnosis. Certain disorders are exclusive in young. For example, inflammatory arthritis in young is usually juvenile idiopathic arthritis, and they have different patterns. Autoinflammatory diseases, which usually present in the pediatric age group, reactive arthritis. Certain other syndromes like hypermobility will also have their onset very young. In the middle age group, most of the connective tissue disease as well as rheumatoid arthritis would be, and a lot of other musculoskeletal disorders related to injury, chronic pain syndromes, these all usually manifest in middle age. Whereas in elderly, degenerative joint diseases like osteoarthritis, crystal arthritis like gout, which is associated because of aging, will also increase the risk of metabolic syndrome and hyperuricemia. Polymyalgia rheumatica, which usually causes diffuse pains, and it's more common in it exclusively occurs in patients who are above 50 years of age. Osteoporosis. So based on age, also we get a fair idea as to which disorders you should be looking for in a patient with joint pains. The first step, of course, is to localize the source of pain. So where is the pain coming from? Is it truly articular or periarticular? Is it coming from somewhere else? So either the pain can be articular or from periarticular structures, or it can be from bone, soft tissue, from the muscles. Soft tissue can be a bursa, ligament, or it can be from the nerves. So all these, or it can sometimes be a remote visceral cause, like for example, shoulder pain, which is well described in cholecystitis. So joint pain need not necessarily localize to a joint or periarticular structure. So the first step is to try and figure out if this pain is coming from the joint. So what are the pain sensitive structures in a joint? So this is a knee joint. It's a typical synovial joint. So the bony surfaces are covered by the articular cartilage. This articular cartilage does not have any nerve ending. So this does not lead to pain. On the other hand, the synovium, which lines the joint capsule, the capsule itself, the periosteum, as well as the subchondral bone will all have nerve endings and will give rise to pain. There are also various ligaments and bursas around the joint. So these also can be a source of pain. So the articular structures that are a source of pain is one is the synovium. And when we talk of inflammatory arthritis, you will commonly hear many of us refer to arthritis as synovitis. So because it is a synovial hyperplasia pathogenetically, or sometimes the capsule can get inflamed. You would have heard about frozen shoulder, which is an adhesive capsulitis. The periosteum can lead to pain. The subchondral bone can also lead to pain. Periarticular structures like bursa. So you can have a bursitis that leads to what a patient will call as a joint pain, a tendinitis, or the insertional areas where, like, you can have pain at the epicondyles, or you can have pain at the condyles of the knee, because these are enthesial points. Enthesial point means a point at which a ligament or a tendon is attaching to the bone. So Achilles tendon is one of the commonest sites of enthesitis. So that can also lead to pain, or it can be remote referred. It can be a neurogenic pain. It can be due to a muscle around the bone, which the patient will call a joint pain, or it can be from the bone itself if there is a fracture. So what is the difference between articular pain and periarticular pain? So your articular pain is what we refer to as arthralgia or arthritis. So when pain originates from the joint itself, it is a deep or a diffuse pain. And one of the most important features is that it leads to pain in all directions of motion. So it's not like a patient will complain of, like, if he has a shoulder joint involvement, then he's going to have, whether he extends his arm or whether he's abducts his arm, he's still going to have pain, and it's going to be on all movements of the shoulder. And it is even on passive movements, the pain will be present. In some joints, the swelling will be obvious, whereas in certain joints, you may not be able to visualize the swelling. The classical example is the hip. And crepitation, instability, locking, and deformity, these are all classical signs of an articular involvement. Whereas periarticular pains are localized. Here you think of like supraspinatus tendinitis. So there is a localized pain which is on the head of the top of the shoulder. And usually there is a point or a local tenderness which is not on along the joint line. The active movements, which is like in case of you have a supraspinatus tendon involved, then your abduction is going to be painful. However, your passive movements are going to be completely free. Physical findings, like I said, are remote from the joint capsule. So that is how you localize whether this is an articular pain or it is a periarticular pain. Again, neurogenic pain will have a kind of aesthetic quality, a burning kind of pain, or that is the kind of quality that it will have. And usually, only if it's a root pain, then you're going to get a pain when you move the affected spine segment. And otherwise, the joint examination will be completely normal. The range of motion will be normal. And this is something that I find extremely deficient in clinical practice, that people do not look at the range of, a lot of people do look at tenderness of the joint, do look for swelling, but the range of motion is never looked for. So resisted active movement also, it will have no effect. And neurological examination may be normal if it's a neurogenic pain. In a referred pain, the palpation and all joint examination will be completely normal. So if it's a joint pain, the other question that we need to do, is it inflammatory? Is it an inflammatory arthritis? So that is an extremely important component of evaluation of a joint pain, because that is going to make a difference in the way you treat your patient. So this is another symptom that we always talk about in rheumatology, early morning stiffness. So we ask the patient, how much time does it take when you wake up in the morning for you to feel better, for you to warm up, for your joints to open up? So we take that time as 30 minutes. So inflammatory arthritis, it worsens when the patient wakes up after a night's rest. It will usually be very bad. The hand pain especially will be very bad, and it will improve on activity. On the other hand, non-inflammatory arthritis, they may complain of stiffness. A lot of osteoarthritis patients will come to you with stiffness. That is classically a gel phenomenon that the patient feels with pain. That is, say he's taken a rest of about 2 hours, he's sitting in one position. When he wakes up, he feels a little stiff. That's more of a gel phenomenon. And it is usually worsened with pain and use of the particular joint. The other very, very important part of the history is, does this pain respond to NSAIDs? All pains will usually respond somewhat to NSAIDs, but usually inflammatory pain will have very, very good response to an NSAID. So this is one history that will help you to kind of figure out if this is inflammatory arthritis or non-inflammatory arthritis. Okay, so the other history is history of joint swelling, which the patient will usually be able to tell you, and history of treatment response to steroids or NSAID. There is a lot of steroid abuse in our country, so that is a history you can ask, that if the patient was just given some dexamethasone and he felt better after that. But history obviously can only take you that far. So the third step is to examine. So we know these classical signs of inflammation that we have been taught during pathology: warmth, pain, swelling, and redness. So no, this is not going to happen usually in inflammatory arthritis. We are only going to get pain, and we are going to get some swelling. And this is the most important finding on examination. The swelling is more of just a bogginess, and it is associated with some limitation of movement. It is not going to be some gross swelling like which you are going to expect. So that's not how it's going to be. It's only very occasional, like if you have a Baker's cyst, maybe you will kind of see a swelling there, but it's not like that. Joint swellings are very subtle, and it takes practice to learn to recognize that this is synovitis. Okay, it is usually not a palpable swelling with margins. It's something that we learn with practice. So always inspect the joint and look at the movements of the joint. Movements, I always say, this is one of the most important thing that is missed, the restriction of movement and the range of movement, and compare it to the opposite side. So that is especially if it is kind of asymmetric, and usually in most patients, not all joints will be truly symmetrically involved. They will be relatively symmetric. So you can always have a comparison from the opposite side that will tell you that this joint is wooden. So just to tell you, this is not how it's going to look. This is going to be a little more subtle. It's just going to be a little bit of a swelling here. You can see the PIP joints are swollen here. So this is how arthritis is going to look in real life. Okay, this is a tophus. So this is not very frequent in today's day and age. Okay, so there are some specific techniques we use to elicit joint swelling and tenderness that is largely limited to the large joints, and this is the bulge sign that we use, where we push medially in the knee and then see whether the lateral we push from the lateral side and see if the medial side bulges. So that's called a bulge sign, which looks for synovitis and effusion before the patellar tap is thought to be able to elicit milder amounts of fluid in the joint. Other than that, and a very important clinical test, we squeeze the metacarpal as well as the metatarsal joints together. That's called a squeeze test. So you can squeeze the forefoot or you can squeeze the hand at the metacarpophalangeal joints. And if it is usually in patients with especially rheumatoid arthritis, because their joints are symmetrically involved and it does involve small joints, you will get a positive squeeze test. The third step, and we should be able to, in fact, diagnose a joint disease before this happens. But yes, you will see patients in India with deformities. So there are numerous characteristic deformities, especially with all the joint diseases. And so you have to learn how to recognize deformities. Here you can see the subluxation of the MCP joints and the mild ulnar deviation of the fingers. So these are some of the classic deformities: the swan neck deformity, which is hyperextension of the PIP with flexion of the DIP joint, the boutonniere, which is the reverse, and the Z deformity of the thumb. And this is called the zigzag deformity, the radial deviation of the wrist and the ulnar deviation of the fingers, along with subluxation of the MCP joints. Usually all these are deformities that are described in rheumatoid arthritis, and these are late stage. This means that the disease has already gone into irreversible damage, and this is what we need to prevent. So the diagnosis has to occur before this happens. So deformities sometimes may also be correctable, like you're seeing here. This looks like a RA hand, but you just place the hand flat on your table and it will go. This can occur in Jacquard's arthritis, which is a sequelae of rheumatic arthritis that occurs with rheumatic fever, and can also be a sequelae of Sjogren's syndrome and SLE sometimes. And sometimes in hypermobile situations, like you have in the Ehlers-Danlos, you get very hypermobile joints. They may actually look like this, and you can see that they're completely reversible. And of course, we forget to examine the foot. So the deformity may also be in the foot. So don't forget the foot. And the other, I didn't put it on the slide, but don't forget to examine the spine. Arthritis can start in the spine. The fourth step is pattern recognition. So pattern recognition, this is the central part of diagnosis of inflammatory arthritis, because our diagnoses are largely clinical. So we have to look at number of joints involved. Symmetrical in the sense that it is going to be relatively symmetrical. It means that in both sides PIPs are involved, both sides MCPs are involved. It won't be the same MCP on both sides. It's a relatively symmetrical disease, but a lot of even RA can have a completely asymmetrical onset. It doesn't rule out rheumatoid arthritis. What joints are involved? What is the pattern? Whether it's upper limb joints, lower limb joints, whether there is an axial involvement or not, which means is the sacroiliac joint involved, is the vertebrae involved, and what is the sequence? Is it an additive arthritis? Is it a migrative arthritis, or is it an intermittent arthritis? All these will give you clues to the diagnosis. So this is pattern recognition. So how many joints are involved? Is it a monoarthritis, that is one joint, 2 to 4 joints, which we call as oligoarthritis, or is it a polyarthritis? So if you look here, from monoarthritis to the polyarthritis spectrum, the probability of infection decreases. We hardly get any septic arthritis or any infectious arthritis that are polyarthritis. I'm talking about true infections of the joint. It may be a para-infectious or a reactive process that can present as a polyarthritis, but a true infection of the joint will usually present as a monoarthritis, a septic arthritis. So once it's oligo or polyarthritis, your differentials have to be different, and infection comes much, much lower in the list. So monoarthritis in the acute, of course, you have to suspect septic arthritis. hemarthrosis. If it's intermittent, a crystal arthritis can present as a monoarthritis. Classic crystal arthritis, the commonest is gout, but there are others like pseudo gout, which is CPPD associated. This also can be usually classically presents with intermittent periods of inflammation. Trauma, of course. Chronic can be tuberculosis, villonodular synovitis, and less commonly the group of inflammatory arthritis. Some of them can have a monoarticular onset and then subsequently evolve into a oligo or polyarthritis. Again, you go to the oligoarthritis spectrum. The acute ones may be a reactive arthritis. It can be rheumatic fever, which presents as an oligoarthritis. And you can have a septic arthritis sometimes, especially gonococcal can sometimes present with an oligoarthritis. Trauma and hemarthrosis will become less common. Of course, crystal arthritis in certain situations can also present with oligoarthritis. So chronic will be the entire spectrum of some of the inflammatory arthritis like spondyloarthropathy spectrum in GIA will classically present with oligoarthritis. Occasionally, RA can have that. So the polyarthritis. So polyarthritis has a huge list of differential diagnoses. So from autoimmune, that is inflammatory arthritis, that includes rheumatoid arthritis, spondyloarthropathies, connective tissue disease, vasculitis, include sarcoid, juvenile idiopathic arthritis. All these can usually present with a polyarticular presentation. Occasionally infections, and the infections that we need to keep in mind which can be polyarticular presentation is subacute bacterial endocarditis. It can be a viral arthritis like you get in dengue or you get in chikungunya. Gonococcal can occasionally present with a polyarthritis. Leprosy is another process which can present with a polyarthritis. Reactive arthritis is the para-infectious and in the list. The others which occasionally can come, paraneoplastic these are rarer diagnoses, crystal associated and infiltrative, and carcinomatous crystals, hemochromatosis, these are much rarer diagnosis of polyarthritis. So what are the patterns? So this is how rheumatoid arthritis will look. Symmetry, of course, is not absolute, but you see this is relatively symmetrical. Here, the PIP joints are classically involved. MCP joints are involved. Wrist will be involved in almost all the patients. The elbow, the shoulder. Okay, so it can involve the other joints, including the TM joint, the sternoclavicular joint, much less commonly. The knees, the foot joints will be classically involved. What you need to understand here is that the DIPs will be spared. The axial skeleton other than the neck can be involved, but the rest of the axial skeleton will be spared. So that is how rheumatoid arthritis classically presents. Not all patients may present similarly. Some patients may evolve over a period of time. They may present with just bilateral wrist involvement and subsequently have evolution to involve other joints. This is rheumatoid arthritis. This is representing the spondyloarthritis spectrum. So here the classical involvement will be there are many types of psoriatic arthritis, but this represents the peripheral involvement more than the axial. I will come to the axial. So here the arthritis in some occasional patients it can be RA-like, but in others it can be completely asymmetric. You can have a swelling of an entire finger. This is called a dactylitis. The entire finger will be swollen. Usually the lower limb arthritis is asymmetric. Again, this represents the dactylitis. There is something called an enthesitis. So usually that presents in the Achilles tendon. You get a swollen Achilles tendon. And you get an asymmetric sacroiliitis that is usually presents as lower backache or a buttock pain. So that is called a sun ray pattern of involvement. This is a psoriatic arthritis. This is how an axial spondyloarthritis presents and usually involves the spine symmetrically as compared to reactive or psoriatic, in which it is a little more asymmetric spinal involvement. This involves the entire spine symmetrically, and the peripheral joint involvement of spondyloarthropathy is predominantly large joint, involves the root joint like shoulder and the hip, and tends to be asymmetric. This is a figure representing the joint distribution of osteoarthritis. So here you see again the weight-bearing joints, the hip and the knee involved, the first MTP involved. Your CMC joint, which is usually not involved in inflammatory arthritis, will be classically involved here, and your DIP joints, which are spared in RA, okay, DIP joints can be involved in spondyloarthropathy spectrum and in osteoarthritis. So here you can see the involvement. This is and OA, in which you get involvement of the PIP and DIPs. These are called Herberdens and Bouchard's nodes. So this is another very common joint problem, commonly seen in women. So when you look at this, what we call as an RA pattern arthritis does not equal to RA. Although RA may be the commonest diagnosis in an RA pattern arthritis, but it's not equivalent to RA because it has a host of causes. Because RA obviously can present other connective tissue diseases, psoriatic arthritis, vasculitis, sarcoid, Still's disease, JIA, all these can present with an RA pattern arthritis. Post-infectious arthritis, viral arthritis, leprosy, pseudo-gout, all of these can present with a typical RA pattern. So it's not like RA pattern is a very specific pattern of arthritis. When you have deformities, once you go into deformities, especially the typical deformities that I showed, mostly it narrows down the diagnosis for us. Once we get deformities, there are only few arthritis that lead to joint deformities. Among the inflammatory arthritis, rheumatoid arthritis, juvenile idiopathic arthritis, Still's disease, mixed connective tissue disease, and spondyloarthropathy, all the forms can lead to deformities. Extra-articular manifestations. So this is extremely important because the presence of any extra-articular feature is what will lead you towards a diagnosis, and these diagnoses may be very, very important because some of them may be red flag signs, some of them may require urgent referrals. So cutaneous involvement, typical of, you may see cutaneous involvement of systemic lupus, of dermatomyositis. You may have Raynaud's, it may suggest a systemic sclerosis or a dermatomyositis. Mouth ulcers, again, that Behçet's disease may just present it as joint pains. IBD may present as joint pains, which belongs to the spondyloarthropathy spectrum. Subcutaneous nodules, which may be part of rheumatoid arthritis. You may see tophi in gout. So erythema nodosum, which may be part of sarcoidosis. So huge number of mucocutaneous manifestations, and there may be a cutaneous vasculitis. This must alert you to a systemic vasculitis or to a lupus. And several ocular manifestations, uveitis, which is classical of the spondyloarthropathy spectrum, scleritis, which can occur in RA and vasculitis, and renal, which should alert you towards either a lupus or a vasculitis, and numerous cardiopulmonary manifestations. So any neurological, like mononeuritis multiplex, which can be a feature of vasculitis. Vasculitis can sometimes just initially present as an arthritis and just some subtle cutaneous or neurological manifestations or ENT manifestations in granulomatosis and polyangiitis. So you have to take a good history to figure out if there is any systemic involvement, and this may be very, very important because a lot of these diseases are red flags and you need urgent referral. Okay. So fever is not common, unlike we think in inflammatory arthritis like RA. However, fever should alert you to certain diagnosis, like it could be one, and the most important in this will be septic arthritis, but among the inflammatory spectrum, it could be viral rheumatic fever, reactive arthritis, subacute bacterial endocarditis, lupus, vasculitis, Still's, all these may present with fever. So what are the red flag signs that you definitely need to identify the patient with articular features? Fever, especially high-grade fever. So, and a red hot joint. A red hot joint in rheumatology is either septic arthritis or gout. It does not have too many differential diagnoses. And if there are other constitutional or systemic symptoms, you're getting a lot of mucocutaneous symptoms, you're getting, you have hematological features, you have any other features, then you have to get alerted to a systemic disease, a connective tissue disease, or it can be even tuberculosis. You may get a joint involvement and a patient will be having a lot of weight loss and fever. So that should alert you that this is something else. And if you have a rapid progression of deformity, that usually suggests an infection. Inflammatory arthritis are usually subacute and chronic. The deformity will usually come chronically. I mean, after a considerable duration only, you're going to get a joint deformity in rheumatoid arthritis. So if there's a rapid progression, like joint is getting eroded very rapidly, it's definitely an infection and requires urgent referral. So this is a classic rash that we see in lupus, and you can also see she has a mucocutaneous involvement. This is a very classic feature, that nasolabial sparing. This is one of our patients with ACLE. In dark-skinned individuals, it sometimes may be difficult to really pick up the malar flush, so you have to really open your eyes for it. So this is again another patient, but the rash is more subtle. You can see here the rash is raised. It can occur in ACLE. It's a highly photosensitive lesion. So this was another patient who had presented to us with just fever and had very severe joint pains for about 2 weeks and just had this subtle rash. So this was not initially picked up, and he had come to us with hemopsis and finally turned out to have vasculitis. So that is why I'm saying a good general physical examination to look at associated features is extremely important. You can see this is a purpuric rash, and this patient subsequently turned out to have a granulomatosis with polyangiitis and DAH. So a life with diffuse alveolar hemorrhage, which is a life-threatening manifestation. So it is important in all patients of joint pains to really keep your mind open and pick up anything that is unusual, or especially systemic symptoms and signs. Okay, what about investigations? This is one of the very common mistakes that we see in practice, that you just have some patient with arthralgias, just some joint pains, and ESR is elevated and it is labeled as inflammatory arthritis. So it's not, ESR is not such a specific test. We really need to take it with due clinical discretion. So if you look at one cross-section study, even non-inflammatory patients had ESR greater than 13-20% of women and 10% of men. And occasionally we will see inflammatory arthritis in whom ESR can be completely normal. So there's nothing very specific about it. It definitely adds, if you get a very high ESR, then you can't go away from inflammation. But a borderline ESR should not alarm you, and you should really use your clinical discretion as to how important this is. So first, it is rheumatoid factor, and not rheumatoid arthritis or not RA factor. It's RF, not RA factor. Okay, so we and this is one of the most misused tests in practice, and I think a lot of people don't know how to interpret this test, and this leads to a lot of errors. So any patient with joint pains and rheumatoid factor positivity is not RA. So because it's a very, it's not an extremely specific test, neither it is very sensitive. You will see that only 70% of rheumatoid arthritis are seropositive. Thereby, we have a huge proportion of rheumatoid arthritis patients itself who we call seronegative rheumatoid arthritis. Thereby, a negative rheumatoid factor should not rule out the rheumatoid arthritis. Rheumatoid arthritis is a clinical diagnosis. In fact, even in psoriatic arthritis, juvenile idiopathic arthritis, and systemic lupus, Sjogren's classically tends to have rheumatoid factor positivity, which is extremely high titer. And these patients usually come just with joint pains and some sicca symptoms, and are often labeled RA. Scleroderma myositis, infections, you will have many of these chronic infections which leads to immune stimulation. So any form of generalized immune stimulation like tuberculosis, leprosy, infective endocarditis can actually lead to a rheumatoid factor positivity. So there are other conditions like essential mixed cryoglobulinemia, HIV, hepatitis B, all these conditions which chronically have B cell stimulation will have rheumatoid factor positivity. So there is, and some of them, especially in conditions like hepatitis C, in hepatitis B, you're going to have extremely high titer rheumatoid factor. So that should not lead to a diagnosis. You should be very careful with your interpretation. So titers are of importance here. When you look at at increasing titers, if you look at a titer greater than 100, obviously the sensitivity will go down, but the specificity becomes quite high. And at greater than 300, usually most of the patients are RA. So titer is very important in rheumatology. So just positive means nothing. Like usually if I'm getting a rheumatoid factor of 25, 30, I would most in all likelihood ignore it. What about anti-cyclic citrulated peptide? This is an autoantibody that has come more recently in the last 10-15 years. And it's got a very high specificity for RA. That is in healthy controls is 99%, in disease controls 95%. That is only 1% of healthy controls will have anti-CCP positivity, and 40% of rheumatoid factor negative patients will be CCP positive. Sensitivity is almost the same as rheumatoid factor, maybe slightly more in established RA, but the important thing here is specificity. When you're in doubt, anti-CCP can yield an answer. What about ANA? So having an ANA positivity does not equate to having lupus. ANA is not equal to lupus. ANA is a sensitive test, but it is not specific for any disease. It is positive in a large number of autoimmune diseases, may also be positive in the general population in infectious diseases and drug-induced. So that is why it's important to understand that none of our autoantibody tests are specific. Okay, they have to be based on a due. You should have a pre-test probability to really be able to interpret these tests. Again, there is a this is ANA should classically be done on a test by a test called indirect immunofluorescence. We see a lot of people using these ANA blot tests, which will give you a bunch of autoantibodies, which will be very, very hard to interpret even for without clinical context. I often get in any patients with chronic tests with the chronic pain with a bunch of these autoantibodies, and they will be very mildly positive. And I'm often asked, what is the significance? Mostly they have no significance. So titers are very, very important, because if you look at low titer, it is in 20 to 30% of the population at 1 in 40 will have a positive ANA. In St. John's, we start at a titer, we report positive only when it is positive in 1 in 100 dilution. As you go up, the obviously the specificity of ANA goes up for a rheumatological disease. So these are all the diseases again in which ANA testing is helpful. There are a bunch of them. It's not just lupus, it's systemic sclerosis, myositis, there's Sjogren's syndrome. Okay, so this is from Harrison. This is a very important table and very good table, which actually, sorry, I think this is from Kelly. So in drug-induced lupus, in some diagnosis for us, ANA is required. And in some, it may be useful for prognosis. Like if you have a Raynaud's phenomenon, a patient presents to you with discoloration of the hand on exposure to cold, then an ANA might tell you that this is the kind of patient who will progress to having a connective tissue disease. But in all these diseases, it's typically not usually helpful. It doesn't really, like in patient who seems typical of a rheumatoid arthritis, you are getting a rheumatoid factor positivity. The symptoms are typical. There are no any odd extra-articular features, and it is rheumatoid arthritis. There is no need to do any ANA, and ANA positivity is not going to really add anything to your diagnosis. Okay, so this is a patient you're going to treat like rheumatoid arthritis. So doing an ANA really will not add. Fibromyalgia, patient with chronic pain syndromes, a huge proportion of them are going to have ANA positivity, especially in low titers. Again, you are always racking your brain as to what to do with them. So that is why a history and a physical examination should do that for you, and only basic investigations are required for you to know that, okay, this patient does not have anything else that's alarming. So if you just look at 10,000 unselected ANA tests, and if you take a 5% false positivity rate, 500 ANAs will be positive, but only 1% will have, 1 in 100 people will have a disease. So, you know, there's a large number of false positives. So pre-test probability is important. So ignore a positive ANA in low titers, especially when it's not having any clinical, none of your clinical syndrome is really matching to that ANA. And a negative ANA test is sometimes more valuable than a positive result. Okay. So another test that we commonly do in clinical practice is uric acid. Again, one of the most abused lab investigation. So arthralgias plus increased uric acid is not equal to gout. Gout is an inflammatory arthritis. Patient will come to a red, hot, swollen, extremely painful joint, and it's classically, it starts off as episodic. Over a long period of time, it becomes it progresses from intermittent to polyarticular to, you know, continuous joint pains. And TOFA is a late symptom. And I get women who are diagnosed with gout, I mean, it is extremely uncommon in premenopausal women, unless there is any other risk factor like renal failure, or patient has a psoriasis, or patient has some other condition which causes a metabolic condition which really leads to increased uric acid. And diagnosis of gout is not by uric acid. Diagnosis is based on demonstration of crystals in joint fluid, which we do by a polarizing microscope. And but in a patient who has a typical sign and symptom, like it comes to you with first MTP involvement, it's a red hot joint, and is giving a history that, you know, after some dietary this or alcohol intake is developed, then yes, you will make the diagnosis of gout. And uric acid may be falsely low during an acute episode, so it has to be repeated. So the most important point here is, don't do you. I mean, it is important to understand that just on uric acid is not even an essential investigation for most inflammatory arthritis. I only do it when I have a suspicion of gout. This is how gout looks: a red, hot, swollen first MTP joint. It's extremely painful. So what about chronic widespread pain? So a lot of patients in your clinic will come to you with, you know, I have pain everywhere. So some of them will be, so usually the joint examination in these patients will be normal sometimes, and this you will not be able to, it's not truly a regional pain. So that should give you the first clue. And when you examine the joint, you will see that the tenderness, especially in something like fibromyalgia, it will be tender all over. It's not just the joint line. On the other hand, when you have an articular condition or a periarticular, it will be restricted to that area. It will, in a joint, in an arthritis, it will be restricted to the joint line. When you're touching a bone elsewhere, you're not going to get pain. On the other hand, in fibromyalgia, there are classical tender points. They're not joints, they're tender points. So that will give you the first clue that this is not an articular pain. This is a chronic widespread pain. There are some patients with hypermobility. The joints will be extremely hypermobile. These patients tend to have chronic pain. You can, there is a criteria that we use for diagnosis of this hypermobility. You can just look at the thumb hypermobility, or look at the knee hypermobility, or make them flex the back and touch the floor. They usually be able to touch the floor with their palms open. So this is a primary hypermobility. We call it benign hypermobility syndrome. This is associated with chronic pain. Polymyalgia rheumatica in older individuals. Numerous endocrine causes may be associated with diffuse pains like hypothyroidism, osteomalacia. So again, another very common investigation that's done is vitamin D. There have been a lot of studies. It doesn't really help to give vitamin D in chronic widespread pain. But osteomalacia is different. Osteomalacia is when you have a severe vitamin D deficiency. That tends to be extremely painful. Hyperparathyroidism, and certain drugs may also be associated with chronic widespread pain. So these are the classic characteristic features and diagnostic evaluation for fibromyalgia. So it's a widespread pain which is present at least with 3 months, and usually you will get other disturbances. You'll get fatigue, you're going to get sleep disturbances, and other associated features like your pain syndromes, like you can get an irritable bowel, you can have a bladder syndrome, or you can have cognitive disturbances. And widespread multi-site tenderness, which is not limited to the joint. Sometimes they may even wince on you pressing the joint, but usually there will be no joint swelling, no evidence of any restriction of movement of the joint. And usually your laboratory testing will be normal. You don't need to do a rheumatoid factor in this patient. Okay. So they usually talk like, I hurt all over. Okay. And I like this statement, so I put this. It's not a fishing expedition. Avoid screening rheumatology. Yes. And if you are in doubt, you can go with an early subspecialty referral. So don't just do all battery of tests for, especially, so, and just because a patient comes with pain, clinical discretion is the most important thing here. So diagnosis is always clinical and supported by the lab. Examination is very important to pick up synovitis and joint swelling. Pattern recognition is a key. Early referral when required to a physician or a rheumatologist. Okay. So I leave you with this. RA is not a joint disease. RA is a systemic disease with predominant joint inflammation. Okay, so these are diseases that require early referral to a physician or a rheumatologist because they are systemic diseases. They have early treatment is the only way that they are going to, their long-term outcomes are greatly impacted by early referrals to rheumatologists who are going to treat them the way they should be with aggressive treatment. We treat all inflammatory arthritis extremely aggressively now to prevent long-term damage and the ravages of the disease. So that's why I'm leaving you with this and a few acknowledgements. Thank you. So I'll be happy to take up any questions.
Thanks a lot, Benzeeta. That was just absolutely riveting. I learned quite a lot. And I think Oliver has been collecting some of the questions, though I can ask y'all to also, if you have questions even now, you can instead of putting your hand up, just type it out in the chat and then we'll be able to get to them. But we'll start with the questions that have already come in. So I'll ask Oliver to read them out to you and then you can go through them.
Yeah, we have one question is, what are the preventive measures to be taken for rheumatoid arthritis?
So largely there is the single most important environmental factor for rheumatoid arthritis is smoking. So that's one thing you have to strongly advise your patients. So you can't change your genetics. About 1/3 of the susceptibility comes from genetics, which is not in your hands. But other than that, the most important environmental factor is smoking, which unfortunately a lot of people are not aware. So if you have smokers, you are not going to get good control without them avoiding smoking. It's also most important. I would say that's the most important preventive measures. The rest have a very doubtful association with rheumatoid arthritis. That's viruses and food. And we are not very sure whether these exposures actually lead to increased prevalence of rheumatoid arthritis. Only smoking is absolutely proven.
Okay. Then another question that we have is, how do we demonstrate crystals in the joint for gout?
Okay, so
in a rural center.
Actually, you can see it on plain microscopy, but classically to actually demonstrate it, you would require a polarizing microscope. So you would require a polarizer. That's just a kind of attachment that you add to a regular microscope, and that really I don't think it's easy to acquire it in a rural area. So yeah. So that's how but you don't always need to demonstrate crystals to make a diagnosis. If you have a typical symptom and it is a red hot swollen joint and the patient comes to you like that, and even if at the point of the episode you do not have an elevated uric acid, you can repeat it subsequently. And usually it will be elevated. So it has to be elevated, then only you can make that diagnosis. Otherwise, you'll have to consider other crystal. It still can be crystal like CPPD, but that's much less common in terms of prevalence.
Okay, then the other question that we are getting is that in a patient who's diagnosed with rheumatoid arthritis, how do you go about starting the treatment for the patient? Like,
so I think I really believe that the government of, this huge teleconsultation thing that has come in now, and rheumatology is a specialty that is really can be really applied in the teleconsultation. So I would say that in case we could go that way, as long as you have the primary physician who is examining the patient and telling you that there are no alarm signs, and we could evaluate patients who have no access to a rheumatologist. We could evaluate them by that facility and we could take it further. So it is possible, and in fact we were working on a project like that, because we truly believe that as long as you have a primary physician who is doing whatever requires to be done, including the examination that has to be done.
Correct. No. Now, for example, most of our rural born students, that when they're dealing, they don't have access to teleconsultations with rheumatologists. So what is the treatment that they can give these patients for rheumatoid arthritis?
For acutely, if you're kind of sure it's an inflammatory arthritis, NSAIDs and steroids are what we give, but steroids are to be given for a short course and in the minimum dose. So that is something that we do immediately for a flare. The basic investigation that we need for any arthritis before starting treatment is just a blood counts, LFT and a creat. Okay, so that, and if you are ruling out, like especially if you want to rule out CTDs, all you need to do is get a urine and get a chest X-ray. So that will give you the basic workup, and that is usually available in all centers. Okay, but without, and I see this mistake happening, that's why I'm stressing, without baseline investigations, do not start a DMARD. It should not be started. It is a huge mistake.
Should not start off, sorry?
Start a DMARD, disease modifying anti-rheumatic drug, No methotrexate, no sulfasalazine, no lefno without basic investigations. It should not be done in capital letters.
So basically, we can just start them on gradual painkillers. Start with paracetamol and then
Yes.
upwards.
Yes. If you have a create NSAIDs, or if you feel that, you can always give NSAIDs. We are, as a rheumatologist, we are never scared of NSAIDs. We do give a lot of NSAIDs. A lot of us spondyloarthropathy patients are on long-term NSAIDs. So there is no need to be scared of NSAIDs. Just if you are going to give NSAIDs for a long time, then you have to repeat the creatinine. So if you're not, if you're just going to give short courses, then it's okay. You can give a week to 15 days. Usually we give up to 15 days of NSAIDs. And but if the patient is requiring a lot of NSAIDs, it means that you need to, obviously, every rheumatoid arthritis patient needs to be managed aggressively. And it cannot be just with NSAIDs and steroid. It has to be disease-modifying anti-rheumatic drugs. It has to be done early because that is the only way to prevent long-term damage and deformity. Yeah.
Robert, yeah.
Benzeeta, there's a question from Sitara. She says, one, I think you just answered when it said, can we treat empirically? I think you just answered that. But it says in the periphery, what are the medicines that we can use safely when there is no access to a rheumatologist?
That's what I'm trying to say. The only thing that I can usually give when it's not about access to rheumatologists. It's about access to these investigations. You have a normal complete blood count, you have a normal LFT, and you have a normal creatinine. You can start a DMARD. There is no problem with that. You can start it, you can go slow, increase the dose with monitoring and with appropriate counseling. But one has to be, the problem with these drugs is these do cause severe side effects. So methotrexate overdose does cause neutropenia. It has caused deaths. So you cannot use them loosely. That's all I'm trying to say. Anybody who, if you want to use them, you can, but do it with the appropriate pre-investigations, do it with the appropriate monitoring. So usually after we start methotrexate, in 15 days to a month, we call back with the CBC and with the LFT and creat. So that has to be done. Just because it is a rural setting, it cannot be reached.
I think several are asking here, about 4 or 5 people. We are in the periphery, okay, and we get a lot of geriatric patients who have other chronic conditions also, whether it's diabetes or hypertension, and they also come with joint pains. What kind of treatment can we give them which is safe for them in the peripheral area, considering we're not going to do any other investigations?
See, hydroxychloroquine is one thing that is safe. All you need to do is a baseline eye checkup. Again, that is again a problem. You need to do a baseline eye checkup. See, that is largely the issue with most of our drugs, that they have a bunch of side effects. So HCQ is still safe if you're going to give it for a couple of months, then it's okay. But longer course, it does require an IV evaluation. Steroids, short courses, long courses again have side effects. And sulfasalazine, all of these DMARDs, the ones we call as disease-modifying drugs, will require investigations, will require monitoring, especially when patients with comorbs and patients who are older will have higher risk of side effects. So I really don't know how else to answer this question. I mean, I just have to say one thing to all people in the rural area, that a patient who is coming to you is showing a health-seeking behavior. And if he's showing a health-seeking behavior, you have to inform him. If he refuses to go to the next person or to the physician around there and refuses to get evaluated, that is a different issue. Then you have to manage the way you can. But you have to offer him and to the appropriate person. You have to tell him that this is the person to whom you need to go for an evaluation, and that is the best thing for you. Because these deformities are irreversible.
Yeah. Oliver, you have more questions?
Okay.
Yeah, I'm just...
continuing on with the same thread, Sister Manju Rose has a question, and I think it ties in with what you're saying. If they've come to you for help as a health caregiver and they're not able to reach the next city or the next thing, is it possible for us as a group to share the protocol of drugs and the dosage which they can use?
Surely, sir.
And can we put that onto our WhatsApp communication with the bonders, and then we can disseminate it?
Yes,
once you share that. Yeah.
I would actually prefer that they could discuss cases with us. We'd be open to that, and they could just share the images or have a video consultation with the patient, and we can help them out there. or send. See, all I need for starting a DMARD, like I said, is just a CBC, LFT, and a creat. I'm okay after that, and I need to explain to the patient that they can't get pregnant and it's a teratogenic drug. So these implications are huge. We have to understand. So there are patients who get pregnant on methotrexate and come back. So we need to understand. That's all.
Thank you.
Shiny is asking, what if only uric acid level is elevated significantly, and it's just incidentally found out, asymptomatic?
Yeah, then asymptomatic hyperuricemia just requires a modification of the risk factors that are there. It's usually due to metabolic syndrome. And if the patient, there is not much evidence to say that asymptomatic hyperuricemia needs to be treated. Usually we would treat if it's above 10, but below that we just ask them to modify usually it's associated with metabolic syndrome. So just lifestyle modifications are recommended, and you could ask them to avoid. This is also another very, very common mistakes. You tell your patient to get off all protein and kidney beans and all that. It's not required. Dietary modifications can make a change. This has actually been studied from a study that even with very stringent dietary modification, the change in uric acid that can be expected is just 1 milligram per deciliter. So the only 4 things that really needs to be recommended is no alcohol, because it leads to fluctuations of uric acid. No fruit juice, because of the fructose monophosphate shunt, which can lead to fluctuation in uric acid. Seafood and organ meats and red meat. So that's all you need to say. These foods are avoided. Lifestyle modification, lose weight, diabetes control, lose weight especially, that's very important. But usually patients who have very high uric acid levels are due to some other metabolic disorder. So that requires investigation.
Okay, we have a question from a Dr. Randall. It's a little long one, so I will read it out to you. What kind of diagnosis can you give patients typically with an undifferentiated arthritis, commonly in women, with overlapping endocrine illnesses like hypothyroid, PCOS, and weight gain? How do you treat this? Primarily treat the joint problems or the endocrine issues? And what is the role of stress in worsening symptoms, work or personal life related?
Okay, so to answer the first part of your question, see, articular symptoms need not be an arthritis. Okay, so there are a lot of endocrine conditions like hypothyroidism, hyperparathyroidism. Even diabetes is associated with a bunch of musculoskeletal conditions. So first is to really figure out how much your endocrine abnormality is really contributing to the pain and all. If you do not have evidence of true inflammatory arthritis, when I said this is really boils down to a good clinical examination, and if your joints are seemingly normal, and I think one of the, like I said, the most important thing that we miss out, if your joints are swollen, the range of motion will be affected. And I've seen that people don't really examine the wrist. You can't really freely move your wrist if this is swollen. So you have to look at that, make a clinical diagnosis. If you still think this is a clinical diagnosis of inflammatory arthritis, which is independent of the endocrine disorder, then you will treat both. Okay, you will treat the endocrine disorder like hypothyroidism, because again, most of the autoimmune diseases will have a very high incidence of hypothyroidism. There is an association. Even hypothyroidism is an autoimmune disease. So, okay, there may be association. So you will treat both independently. But if you believe the musculoskeletal condition is related to your endocrine disorder, then treat that more aggressively. If the patient is, ensure that the patient is euthyroid or whatever. The other question, stress. Frankly, I don't think there is any study which has shown that there is any association of so-called psychological stress with inflammatory arthritis, whether the rheumatoid arthritis flares are associated with psychological stress. No, there is no study that has really proven that. But stress has got other implications. Usually what happens is when a patient is stressed, we get a lot of pain is also, there is a central sensitization of pain. So we always deal with a central sensitization, and patients have a lot of overlap of this fibromyalgia syndrome with inflammatory arthritis because of the central sensitization, and that is exacerbated by stress. So usually true inflammatory arthritis, does it exacerbate with stress? No, not that much evidence, but yes, the other psychosocial comorbidities, definitely.
We have another question from Dr. George Clarence. Is there a recognized entity called post-viral arthralgia? What would be the diagnosis and line of management in a patient who has polyarthralgia, moderately elevated ESR, but is seronegative?
Okay, so classically, post-viral arthritis and arthralgias are seronegative. They tend to be usually RF and anti-CCP negative. That is documented in literature. One of the most common syndromes that we see here is post-chikungunya arthritis. And this is very common that patients have very severe pains and can go up till, studies have shown that they can go up till 2 years to 5 years post-viral pains and musculoskeletal conditions associated with chikungunya virus. So how do you manage that? See, if you're really, that is the thing, the evidence is not very strong here. We do not have anything like randomized controlled trial, which has really looked at this. So, but I did some work on chikungunya arthritis. It's yet to be published, but we have seen that in patients with frank arthritis, which means that there is a swelling of the joint, there is synovitis, we treat them just like we treat rheumatoid arthritis. However, if there is no clear evidence of inflammation in the joint, then what we do is manage them more conservatively. We just give them NSAIDs, a course of NSAIDs, and see if after 15 days to a month they improve. In some patients, hydroxychloroquine has been tried in literature. That again is a safe drug, so you could try it in your rural practice. You could, because short-term hydroxychloroquine doesn't really have any much impact on the eye, and you don't, unless you're planning to give it for months on it, you don't really need to do an eye screening. If you're just going to give it for 3 to 6 months, that's another drug that can be tried. Methotrexate has been tried in post-viral arthritis with very good outcomes. So in our experience, in most of the post-viral arthralgias or arthritis, which we have treated with short course of steroids and methotrexate, patients have had very good long-term outcomes. So you could, in a patient whom you believe that the pain is driven by inflammation, you could give a short course of steroid, which means usually we would give an IM steroid. We give injection dipometrol or injection Tricot 80 milligram once, or we give a Vicelone at doses of less than 7.5, 7.5 milligram, and taper it off quickly. That's how we would approach it. It's a very common problem, chikungunya and post-viral arthritis.
Then what are the kind of non-pharmacological treatments that can be given for inflammatory arthralgias?
See, actually, again, this boils down to really, this is really practice, and this is not truly evidence-based. Okay, so we say this hot joint, cold joint, hot. So it actually works. So if you have a really inflamed joint, then cold compresses really work actually. So that's one of the physical modalities that work. It's not going to, this is only going to aid with the pain. So we have to understand that none of the physical modalities are really going to take care of the inflammation. So if you can't replace, you can just supplement with any of the I mean, if you have access to shortwave diathermy, and all of these have been tried, but mostly they usually use wax, or they use hot and cold. Cold compresses or wax has been used for arthritis. Both of them have kind of limitations, but the fact is, what I want to say is they are just supplementary and can only deal with the symptom of pain and not the cause.
The last question is a follow-up to the post-viral arthralgia question.
Mm-hmm.
Is there a role for levocarnitine in muscle cramps associated with that kind of illness?
Frankly, I don't know. I've never used that drug. I'm really sorry. I've never used levocarnitine. Sorry, I really don't know. I'll have to look up. I can look up for you, but I mean, these are things that for me belong to the category of placebo, and I use them when I just want to give a drug to get the patient off my back. Yeah, I really don't know. I use glucosamine otherwise. That also has no evidence, but you know, some patients like it.
Okay. Are there any more questions?
I think anyway, those were very interesting questions. And a common question that has come right through is that we are out there in the rural areas, and we do need to treat these patients who come back to us, and and we have the limitations of advanced testing and other investigations. And so even if it means methotrexate and other things, like, we'd be really grateful if you could share the dosage and the problems associated. Because
we can, I think I can work on a kind of brief approach or protocol of the initial treatment, and at least we could start off treatment, and because advanced investigations are not required. That's what I'm trying to say. Basic investigations are absolutely required. So that's the difference that we have to understand. Basic, yes, required, but yeah, those we cannot do anything.
Okay. And anyway, just for your information, Sister Manju wants to reply and say that she has used levocarnitine and it works wonderfully well in the rural setup to reduce cramps. So maybe something we can start
God's
using
plan
now.
is
Thank you.
the same
Thank you,
thing.
Sister Manju. Maybe we should try actually.
Yeah, so that's good.
Yeah.
So thank you to you, Benzeeta, for this really insightful talk and for initiating our webinar series. And I do hope that all of you found it useful. And I earnestly request you to send in your ideas of what other topics you would be interested in knowing about. As a follow-up to Dr. Benzeeta's talk, we will share with you the protocols. She said she will work out some protocols for initiating treatment for arthritis, both general and specifically maybe rheumatoid arthritis. And we will share that information with all of you. And between Oliver, Mario, and Sister Beena, we will be inviting you to other webinars to for things that are useful. So I request you to please send in your requests of what topics you're interested in. And we have the alumni email, which Oliver put in the chat box, which I think you're not going to find, but it's very easy. It's SJMCAA. So SJMC and Alumni Association AA @gmail.com. So do send in your topic interests and any other specific questions you have to follow up on this. So with that, I hand it back to Oliver for him to say the official thank you and the vote of thanks.
Thank you very much, Dr. Benzeeta. That was a very, very informative talk. And more importantly, thank you for helping us answer the queries that our doctors had. I also wanted to thank Dr. Mario and Dr. Tony for helping us set this up and getting the word out, especially to our bonders and the sister doctors of the SDFI. We will be definitely having at least one of these webinars every month. We will try and schedule it mostly for a Friday at this same time, as this turns out to be a very convenient time to you all. And please do send us feedbacks on topics that you all would like to have talks on. As we set up the next talk, we will give you all heads up at least about 2 to 3 weeks in advance.
And a heads up, next Saturday on the 3rd of October is the Prakash Shetty Memorial Lecture. So Dr. Soumya Swaminathan, very, very famed doctor who I had the pleasure of knowing first in Chennai, then she was in Delhi, she's worked with WHO now, will be speaking. So please look out for this information. We've sent it on all the WhatsApp groups. That's next Saturday. And yes, George Clarence, he doesn't like the word bonders. I don't know. I never understood how that word came anyway. We're all doctors working in rural areas and they're doing a phenomenal job. So hats off to you. Please all stay safe.
And please do stay safe. Yes.
Thank you all very much. You're much better off there than in Bangalore, I can tell you right now.
Yes.
But thanks a lot and good night, everyone. Have a good weekend. Thank you again, Benzeeta.
Thank you.
Thank you, Benzeeta. Thank you.
Bye, Mario, Oliver.
Bye.
Good night.
Bye. Good night.
Good night.